Assalamu alaikum, everyone. My name is Dr. Abdullah Bukhari. I'm a consultant medical oncologist at Shaukat Khanum Hospital. I would like to introduce my chairs first, Dr. Habib Khan. He's a consultant oncologist at University of Saskatchewan, Canada. Dr. Habib, could you please come on the stage, please? And I would also like to introduce Dr. Kulsum, who is a consultant medical oncologist at Shaukat Khanum Hospital. On behalf of the organizing committee, I would like to welcome you all at the 21st Shaukat Khanum Hospital Symposium. This is the breast section and has two sessions. The first session is from 11:20 till 1:20. It has 5 talks of 20 minutes each, and they will be on early breast cancer. This will be followed by a 20 minutes question and answer session. And then we break up at 1:20 for a 40 minutes break. And then we join again for the second session that will start at 2 o'clock. It has 4 talks of 20 minutes each on advanced breast cancer, followed by a 20 minutes question and answer session. I'm grateful to all of our speakers who have traveled from abroad to share their knowledge and experience with us. And I hope you all will enjoy the talks. The first speaker is Dr. Salim, who is a clinical associate professor at University of Saskatchewan, Canada. He's a principal investigator for Alliance Clinical Trial Group for the province of Saskatchewan, and is recognized as one of the top 10 accruals in clinical trials in North America. So we'll start with Dr. Salim. It's going to be a virtual talk. Sorry, I didn't mention that.
Thank you very much for your kind introduction. Today, I will be discussing an individualized approach to the management and treatment of HER2-positive early breast cancer treatment. These are members of the planning committee, which are Sunil Verma from University of Calgary, Medical Director, Tom Baker Cancer Center. Susan Dent, Medical Oncologist, Division of Oncology, University of Ottawa, Ontario. Stephen Chia, University of British Columbia, Medical Oncologist and Chair, Provincial Breast Tumor Group and BC Cancer Agency. Daniel Rayson from Halifax, Nova Scotia. This learning program has been made possible with funding from Hoffman-La Roche. This program has received in-kind support from Hoffman-La Roche Limited in form of medical editing at I am Dr. Mohammed Salim, medical oncologist and hematologist at Ellen Blair Cancer Center, clinical associate professor, Division of Oncology. Completion of this program, the participant will be able to discuss patient and disease characteristics, guiding selection of optimal treatment protocols for HER2-positive early breast cancer. Understand the clinical data, supporting the use of dual HER2 blockade and extended treatment in specific patient population. Review new medical data addressing different clinical questions in the management of HER2-positive early breast cancer. The key clinical question we were discussing today, number 1, what are the clinical considerations for neoadjuvant treatment in HER2-positive breast cancer? Number 2, what are the most notable recent advances in the adjuvant treatment of HER2-positive breast cancer? Number 3, how should we select patient who should receive escalating adjuvant treatment beyond chemotherapy and trastuzumab? Number 4, what guides our decision to use de-escalated approach for HER2-positive breast cancer? And number 5, what questions remains on optimizing anti-HER2 treatment? Here are some clinical considerations for neoadjuvant therapy in HER2-positive breast cancer. This slide lists the common, well-known indication for neoadjuvant chemotherapy. Added to this is the last bullet point, which it may allow earlier integration of novel therapeutics into the early stage breast cancer. And we will be talking about this point later. When we review the meta-analysis of EBC TCG, that included 10 randomized trials from 83 to 2002, almost 5,000 patients. Essentially, this graph shows there was no difference between adjuvant and neoadjuvant chemotherapy when we consider the breast cancer specific mortality. A number of trials has assessed the impact of using trastuzumab in addition to chemotherapy in the neoadjuvant setting. Studies often assess pathological complete response rate as an indicator for efficacy of the treatment. When looking at that, and you can see the red bars where the trastuzumab was added across the studies, it shows better pathological complete response rate in patients treated with trastuzumab with chemotherapy backbone in the neoadjuvant setting. However, even with the addition of trastuzumab, the PCR rate never exceeded more than 50%. So looking at the graph, when PCR is obtained, there's a better outcome in terms of event-free survival and overall survival. And you can see the first graph shows all-comer, and then it is divided by whether the disease was hormone receptor positive in addition to HER2 positivity or hormone receptor negative. And you can see when the disease is hormone receptor negative, it has even better split between the curve. Newest study design was looking at the PCR results, and there were 4 arms to this study. Standard arm of docetaxel with trastuzumab in the neoadjuvant setting. The experimental arms included trastuzumab, pertuzumab, and docetaxel, or double antibody without chemotherapy backbone, or pertuzumab with docetaxel. And you can see the best outcome, the pink bars were seen when dual antibody with the chemotherapy backbone was used. And the most inferior outcome was when no chemotherapy backbone was used. So therefore, it became clear that double antibody have a better PCR rate, which may translate into progression-free and overall survival. Whereas elimination of chemotherapy using only double antibody has an inferior response rate. So you can see in the graphical form, there were better disease-free survival when both antibody was used with docetaxel in intention to treat population. Therefore, in summary, while there is correlation with overall survival, progression-free survival, and PCR status, PCR is not recognized as a validated surrogate endpoint for event-free survival and overall survival based on this meta-analysis. This table shows the tabulated data from all the major adjuvant trials when trastuzumab is used. And you can see there is significant improvement in disease-free survival and overall survival with very significant p-values. In spite of all that, there is still a large number of patients who will relapse, and this is that unmet need. Essentially, this is showing in the graphical form the same result from last slide. On this slide, on my left, you can see the result of HER2 positive cancer on treatment in pre-trastuzumab era. And there were early relapses, especially in first 2 years. After 2004, when the Herceptin became available, you can see that early spike has been blunted to almost match triple negative cancer. So it essentially showed over the years, natural history of this disease has changed. Looking more closely at the data from the HERA trial, whether the disease is hormone receptor positive on my left or negative on my right, there is still significant difference between the outcome in disease-free survival. When looking at 10-year results of combined analysis of B31 and N9831 trial, it is quite obvious the two risk factors are the number of lymph node where the disease-free survival decreases as the lymph node number rises, so does overall survival. And also better outcome if the cancer is hormone receptor positive as well as HER2 receptor positive, as against if it is hormone receptor negative. So these are few factors which we will be looking at how to improve survival. So the next logical question is how we can individualize the treatment decision based on patient risk of relapse. And we look at certain possibilities which a new trial may be able to shed some light. So now let us look at some notable recent advances in HER2 positive breast cancer. We have already established the role of dual antibody in neoadjuvant setting. Affinity trial tested in first time with a multinational, multi-country randomized trial, the role of dual antibody blockade with chemotherapy backbone, trastuzumab and pertuzumab versus placebo. It was well-done trial. The primary endpoint was invasive disease-free survival, and the secondary endpoint was the disease-free survival, overall survival, and quality of life data, and everything was collected at the time. This trial was published in New England Journal of Medicine. As a positive trial, you can see the p-value was 0.045, which is significant with a very good, robust hazard ratio. And it met its primary endpoint of improving invasive disease-free survival. Especially when doing the subgroup analysis by the traditional risk factor, whether the cancer was node positive or node negative, you can see the p-value was even better in the node positive subgroup of 0.019, whereas for the node negative subgroup, it was not significant. While looking at the hormone receptor status, that subgroup that was hormone receptor positive did not drive any benefit, whereas the hormone receptor negative subgroup did have some benefit, but the p-value was not significant. Since this trial looked at the primary endpoint, there was not a big safety signal detected when double antibody was used, as you can see the first two lines, and ejection fraction drop was not very significant. Look at how do disease-free survival rate in HER2 positive early breast cancer studies change over time. As expected, the greatest disease-free survival was immediately following the treatment and with gradual decrease because more patients experience relapse. But still, compared to control arm, this difference held with the significant p-value even at 10 years. For the trials that are followed that long, affinity data is not there at the time. I included this slide to show you how across different trials the study population could be dissimilar. Just one point to note, node positive status was the lowest in HERA trial, which was 57%, and highest in BCRT trial, 71%. So we need to keep in mind when comparing trials. Again, this is one of my favorite slides. And I like it because it shows you the difference that we have made over the years. So you see the first slide, which is the gray one, which was HERA observation on without anti-HER2 treatment, and all the way to affinity in the adjuvant setting where double antibody was used. And you can see the difference. There is almost 19% difference over the years. So granted, each step is a small change, but with continued development of the science and improved drug, we have improved the outcome of this very devastating disease. Therefore, based on those results, Projeta was approved in combination with Herceptin and chemotherapy for high-risk adjuvant treatment of early-stage breast cancer. Similarly, it was added to the St. Gallen Expert Census and NCCN breast cancer treatment guidelines. Now, looking at the strategies of post-adjuvant extended anti-HER2 treatment, XTNet trial looked at 1 year of neratinib, which is a small molecular inhibitor of HER2 versus placebo. It was 1-to-1 randomization and primary analysis, invasive disease-free survival, and disease-free survival was looked at. So as you can see here, after 5 years of follow from the time of randomization, the neratinib arm has an absolute improvement of 2.5% in disease-free survival versus placebo. And this represents a p-value of 0.008 with a hazard ratio of 0.73, which was an impressive result. But even more interestingly, when we did the subgroup analysis, it was quite obvious the majority of advantage lie into the group which was triple positive, meaning that HR positive as well as HER2 positive group. And in here, the p-value is even more robust. It was 0.002, and with a wider interval between the two curves. Whereas in the hormone receptor negative group, the curve was practically on top of each other. And this is how we use it. And in our center, we don't prescribe it to hormone receptor negative group. The major dose limiting toxicity that was seen in diarrhea, and there was about 40% grade 3 diarrhea initially. This has been improved by gradually increasing the dose and using Imodium on a liberal basis. Also, after first 2 rounds of treatment, generally the diarrhea improves to a very acceptable level. And we have found this new regimen to be quite beneficial and tolerable. Therefore, in summary, there is benefit in individualizing the treatment to the risk of recurrence based on hormone receptor status or lymph node status. In spite of all that, 30% of the patient will have relapse. As I have shown before, that patient who has residual disease have worse outcome. Therefore, there is a need to improve outcome by using new available drugs. Therefore, this Catherine trial looked at replacing trastuzumab with a drug antibody conjugate TDM1 in 1-to-1 randomization. And the primary endpoint for invasive disease-free survival and secondary endpoint was overall survival, and safety was also looked at. This trial was published after 3 years in New England Journal of Medicine. And very interestingly, the curve separated almost by 11 points at 3 years, which is very impressive with a very robust p-value. And it met its primary endpoint is the improvement in invasive disease-free survival with a very robust confidence interval. You can see clearly A subgroup analysis of invasive disease-free survival revealed a consistent benefit of TDM1 across all stratification cohort and subgroup, including patient with hormone receptor positive or hormone receptor negative disease, patient with positive or negative pathological lymph node status after neoadjuvant treatment, patient with either no residual invasive primary disease or residual disease of 1 centimeter or less than 1 centimeter. So all the subgroup benefited. Another very important endpoint for breast cancer, at 3 years, there were very significant improvement in having less distance recurrences. As you can see, there is some trend toward overall survival, but in adjuvant trial, you need long-term follow-up with, you can look at the safety data. There was one death in the experimental arm. This is a patient who has low platelet and had a fall. Therefore, based on this data, TDM was approved in patient who has residual disease after neoadjuvant treatment. So we have dealt with the escalation part of it, for nose positive cancer, using double HER2 blockade in inflammatory cancer. If they know PCR, using TDM1, and there more improvement needed, but we have dealt with it. The APT trial eliminated adriamycin and sartoxin. Patient received paclitaxel with Herceptin for 3 months, followed by maintenance Herceptin for 9 months. You can see in this graph, there is a 7-year updated data that is showing no difference in disease-free survival. There are a number of trials that have been undertaken to examine longer or shorter duration of trastuzumab treatment. I'd like you to pay attention to Persephone trial. This was a very large trial and phase 3 randomized about 4,000 patients with HER2 positive early stage breast cancer. So in summary, a shorter duration of trastuzumab treatment may result in a similar clinical benefit compared to 12 months, particularly in those patients with lower risk of disease of recurrence like T1B and 0T. Essentially, biosimilar has shown a number of randomized trials to have similar efficacy, and in terms of toxicity, there are no worse signal, especially in terms of cardiotoxicity.
Thanks a lot, Dr. Salim, and thanks a lot, Dr. Abib Khan, for the help. I would like to invite my next speaker, Dr. Fawad Khan. Dr. Khan is the Director of Hereditary High Risk Program at Cleveland Clinic Oncology Institute, Abu Dhabi. He's also Chairman of Primary Care Department at Cleveland Clinic, Abu Dhabi, and Assistant Professor of Family Medicine at Cleveland Clinic, Ohio, USA. Can I invite Dr. Khan, please?
Good morning, everyone. Firstly, thank you so much, the organization committee, for the opportunity today. It's a real privilege and an honor to be speaking today amongst such accomplished physician leaders and researchers. As Dr. Abdullah mentioned, I work at Cleveland Clinic Abu Dhabi, and I'll be sharing my talk on preventive medication in high-risk patients. Who should we treat? So this is the beautiful structure of Cleveland Clinic Abu Dhabi. If you're ever visiting Abu Dhabi, please come and visit us. I have no financial disclosures to report. And just a few seconds to talk about the medical breast program. This was pioneered about 25 years ago by Dr. Holly Peterson. It covers the hereditary high-risk program, the survivorship care, and also the diagnostics. So this is what we have at Cleveland Clinic Abu Dhabi as well, where all the genetic mutation carriers, patients who have strong family history of breast cancer, and ones who have high-risk benign lesions such as atypical hyperplasia or LCIS all go into the high-risk program. Then breast cancer survivors go into the survivorship care, and then abnormal mammograms, benign breast disease, and all symptomatic patients go into the medical breast clinic. These are then managed in a multidisciplinary fashion. Oh, this is the picture I took from our teams in Ohio and Abu Dhabi from the newsletter a few weeks ago. So just to give you an idea about how we manage our pathogenic gene variants, this is an example of a BRCA patient who initially, after getting tested and counseled by the genetic counselor, would get established in the high-risk clinic. From there, these patients are, due to high risk of breast cancer for BRCA 1 and 2, both about 70% risk of breast cancer. They will be seen by the surgical oncology to get counseled and on risk reduction mastectomy. They will then see the gyne-oncology with BRCA 1 having ovarian cancer risk of about 40%, BRCA 2 of about 17%. Would be counseled by gyne-oncology on risk-reducing mastectomy. They would then be seen by lifestyle medicine on the lifestyle modification. And then for tiny risk of melanoma, they will be seen by the dermatology team. And then finally, for the up to 3 to 7% risk of pancreatic cancer, these patients will be seen by the Digestive Disease Institute. So coming back to our talk, the objectives of the talk today are to identify patients at high risk for development of breast cancer, focus on high-risk patients that will benefit most from preventive medication, and review tumor pathology associated with different hereditary syndromes, and appreciate who will be most appropriate for preventive medication. Or in other words, who is at high risk, who to treat, and why treat specific genetic variants. So the breast cancer remains the most frequently diagnosed cancer globally amongst females. And this chart published by WHO last year, the pink color represents the global burden we face, a major public health challenge. The variability of breast cancer remains hugely, where the lifetime risk in certain areas where in Western Europe may be as high as 16%. And as low as 6% in Eastern Asia. We don't quite understand why, but we think environmental factors might have a role to play in this. There is, the guidelines vary for breast cancer screening for average patients, but there is consensus amongst the American College of Obstetric and Gynecology, American College of Radiology, and the National Cancer Comprehensive Network, NCCN, to start screening at the age of 40 and do annual screening. Sorry, this is moving faster. And of course, the screening varies for high-risk patients. So in case of BRCA patients, the enhanced screening starts as early as the age of 25 with MRI screening. And then it goes on with P10 mutations at 30 and so on and so forth. The preventive medication uptake remains hugely low. In a study done in the US, it showed that out of the eligible 16% women, only 4% were on preventive medication. And the study showed the barriers were physicians' time, expertise, and comfort in doing the assessment and offering medication. Also, tamoxifen is viewed as a cancer drug by the patients. So they're fearful of the side effects. Sorry. So let's look at how do we identify high-risk patients. Well, the guidelines from NCCN, ASCO, and USPSTF have been very helpful in identifying high-risk and very high-risk patients. So amongst the high-risk patients, we have the first-degree relative with breast cancer under the age of 50, which comes with twofold risk of cancer. Atypical hyperplasia, which comes with 30% risk at 25 years. Then we have the LCIS, which comes with about 2% risk per year. Using the Gale model, if the 5-year risk is 1.7% or greater, or if the lifetime risk is 20% or greater, using either the Gale model or the IBS or TC risk models. Prior chest radiation under the age of 30, which comes with about 29% lifetime risk, and then extreme breast density, which comes with about 4-fold risk compared to the fatty replaced. And finally, in this category, we have the moderately penetrant genes, which are 7, and we'll look in the next slide. In the very high risk category, we have the 6 highly penetrant pathogenic variants, and we'll look into the next slide. Some of them come with risk of as high as 85%, and then compelling family history. So the landscape of breast cancer genes is changing fast, and this is what we know today. Amongst the highly penetrant genes, which may be responsible for up to 15% breast cancers, we have the well-known BRCA genes, but also PALB2, CDH1, P10, and TP53. In the moderately penetrant category, we have the 7 genes, but 2 worth remembering are CHEK2 and ATM. These are responsible, so moderately penetrant genes are responsible for up to 8% of the breast cancers. And then we have SNPs, which are single nucleotide polymorphisms. This is the new kid on the block. These are low-risk alleles, which individually may not have significant risk, but when combined as polygenic risk score, may have an important role to play in substratifying the breast cancer risk. And they might be responsible for up to 20% of the breast cancers. And this is an article we published last year on polygenic risk score. This is available online on SWH website, so if you wanted to read more about polygenic risk score. This is the list of conditions in which are red flags and should trigger genetic testing. In the list, we have the breast cancer under the age of 50. We have ovarian cancer diagnosed at any age. We have the triple-negative breast cancer following the Olympiad trial and the important role of PARP inhibitors. We have bilateral breast cancer with first diagnosis under the age of 50, male breast cancer, pancreatic cancer or metastatic prostate cancer, Ashkenazi Jewish ancestry, which is less relevant in this part of the world, 3 or more total breast cancers in the personal history or family history, and finally, any abnormal genes running in the family. This is one of the models which is commonly used in our practice called Gale model. It takes a minute to complete with 5 basic questions. It estimates the 5-year and the lifetime risk in women above the age of 35. If the 5-year risk is 1.7% or greater, we discuss preventive medication. It has limitations, and in my practice, I use the TC model, which is also known as IBIS risk model, which I'm sure you also are well aware of. It takes a bit more time to complete, about 3 to 4 minutes. It takes into consideration the biometrics, the reproductive factors, and 3-generational family history. And the latest version also includes the breast density, which is quite important, as we discussed earlier, especially the extreme breast density. It provides the 10-year and the lifetime risks. And we discuss preventive medication if 10-year risk is 5% or greater. This is how the TC model looks like. So let's have a look at who to treat. Sorry, this is moving faster, not in my control. So we target preventive medication for patients with atypical hyperplasia or LCIS, ones who have 5-year risk of 3% or greater, ones who have 10-year risk of 5% or greater, using the risk models, and genetic mutations which predispose to ER-positive cancer, such as BRCA2, CHEK2, ATM, CDH1, and PALB2. So why do we treat specific genetic mutations? So this study done on 50,000 breast cancer patients with looking at association with tumor pathology, published in JNCI 2 years ago. Patients underwent multi-gene panel testing, and the results showed that ATM, as you can appreciate in the green shade, predisposes to strongly ER-positive cancer. Under ATM, we have the CHEK2, also in green shade, predisposing to strongly ER-positive cancer. BRCA1, on the other hand, with a purple shade, predisposes to triple-negative cancer. But you can appreciate a tinge of green color in the postmenopausal age, where primary breast cancers may be ER-positive. The BRCA2 is enriched with ER-positive cancers, and PALB2, quite similar to BRCA2, is also enriched with ER-positive cancers. Another study published in JAMA Oncology earlier in the year on 42,000 patients looked at 9 pathogenic genes. At the top, you can appreciate BRCA1, and on the forest plot, we have strongly ER negative and triple negative cancers. Next to BRCA1, we have the BRCA2, which shows strong predisposition to ER-positive cancers. ATM and CHEK2 both showing strong predisposition to ER-positive cancers. PALB2 very similar to BRCA2, enriched with ER-positive cancers. And then BARD1, RAD51, CND, all predisposing to triple-negative cancers. So therefore, our focus is on those genes which predispose to ER-positive cancers, as we looked at earlier, which include BRCA2, CHEK2, ATM, CDH1, PALB2, and perhaps patients with BRCA1 over the age of 50 if the primary care is diagnosed above 50. We hesitate offering medication or preventive medication to these genetic variants which predispose to ER-negative cancers, including RAD51C and D, BARD1, and BRCA under the age of 50. BRCA1, beg your pardon. So in the preventive medication, we have 4 options. We have tamoxifen and raloxifene, which are selective estrogen receptor modulators, well known to us. Then exemestane and anastrozole, which are aromatase inhibitors. In the premenopausal women, we only use tamoxifen, but all 4 options are available in the postmenopausal women. The aromatase inhibitors, beg your pardon, are not FDA approved and used off-label, whereas the others are FDA approved, but we widely use in our practice all for medication, and they are recommended by USPSTF, NCCN, and ASCO. Well, here's a snapshot of all the major randomized controlled trials on preventive medication. The NSABP P1 trial, which was done on about 14,000 premenopausal and postmenopausal women, tamoxifen versus placebo, showed 50% risk reduction at 5 years, and it maintained this prevention by 50% in the long-term follow-up at 15 years. The second study, IBIS-1 trial, was on a smaller patient number of patients, 7,000, both pre and postmenopausal, but this study was less well received because a number of women were on HRT. It showed 25% risk reduction. STAR-P2 trial was a head-to-head on tamoxifen and raloxifene on about 20,000 women, all postmenopausal, and showed an equal risk reduction at 50% at 5 years, but at 8 years long-term follow-up, raloxifene reduced down to 38%, showing superiority with tamoxifen. MAP3 trial was done over 3 years on 4,500 postmenopausal women and showed an impressive 65% risk reduction But we, in our practice, ask patients to take it for 5 years. And then IBIS-2 trial was done on anastrozole versus placebo on 4,000 postmenopausal women and showed about 50% risk reduction. This also maintained this risk reduction up to 15 years after completion of therapy. And finally, the low-dose tamoxifen study was a small Italian study on 500 pre- and postmenopausal patients and showed 50% risk reduction. This is particularly helpful for patients who are unable to tolerate the standard dose of tamoxifen. The data remains limited for pathogenic gene variants. In the P1 study, the tamoxifen showed 65% risk reduction for BRCA2 patients and none for BRCA1, but this was a fairly small study, and therefore this is an area where more research is required. So the key takeaways from today's talk are: most important high-risk patients to identify are those at risk for hereditary cancer. Short-term risk estimates by using the risk models can be used to guide preventive medication recommendations. And finally, target patients with atypical hyperplasia or LCIS if 5-year risk is 3% or greater, or if 10-year risk is 5% or greater. And finally, genetic mutations predisposing to ER-positive cancers. Thank you for listening in.
Thank you so much, Dr. Khan. We will take questions at the end. My next speaker is Dr. Fahad bin Asad. He is a consultant medical oncologist at Illinois Cancer Center, United States. Dr. Asad has been awarded ASH/IVIG award for his work in paroxysmal nocturnal hemoglobinuria. Dr. Asad, please.
Assalamu alaikum, everyone. Good morning. Thank you very much for having me over here. I truly appreciate the Shaukat Khanum leadership for this invitation. So dive into the topic actually. So today we have HER2-low breast cancer. It has been eluding us for quite some time. How to manage this cohort of people, and this was presented in this ASCO 2022. Kind of a big deal in the post-COVID era. We didn't have anything positive for quite a period of time, and this study came over, so I wanted to share this with you guys today. So HER2 expression, actually, if you look at the HER2 expression, we go by the immunohistochemistry, we go by the FISH amplification, but there is a good number of a binary approach to it. Either it's HER2 low, or it's HER2 zero, or HER2 3+, which is the HER2 positive group. So I wanted to share that this is HER2 positive, which we have 3+ by immunohistochemistry, or FISH positive if this is HER2+, and that is 15 to 20% of the patients. So this is the HER2 positive group that we always focus on with our treatment, with all our treatment paradigms that have been put in place. So what about the group which is down below in this, which is the HER2 1+ or 2+? And this is FISH negative HER2 2+ group. And this is 65%, so quite a substantial number of patients in this group. And we have the HER2 zero or the triple negative 15%. So if you want to focus on the 65% of the group, I think we wanted to see if there is something we can offer them. So this is the ASCO CAP HER2 testing guidelines. So in all the studies that we have done in this HER2 space, we are following this. And this is, if you see in the third row or row in there, HER2 CEP17 ratio. So it's greater than 2 or less than 2. So this gives us the FISH positive, which is the more HER2 positive group. And if you go by the HER2 ratio CEP17 less than 2, then you have the FISH negative, and we have got the HER2 copy number that we go by. So this is oncologists use in the clinical medical oncology world. You really don't need to know this, but this is something that we use in the trial that we conducted. So again, this is to emphasize the point. This is a continuous variable. It's not something fixed. It's not that HER2 positive is this unique group and there is all HER2 negative. If you see by the immunohistochemistry staining, there is quite a wide variation in there. HER2 positive breast cancer, like how much is there? HER2 low is 45 to 60, 55%. HER2 positive breast cancer is 15%, and HER2 negative is roughly 30 to 40%. So this just gives you an idea about the magnitude of the patient number in there. Again, if you go by the hormone receptor status, it gives you a demarcation of the hormone receptor positive versus the triple negative group. And you can see about the immunohistochemical strain of 1+ is roughly 46%. So HER2 low is roughly 63% in the hormone receptor positive group compared to the triple negative, which is roughly 34%. And this is the middle part is our focus group that we are looking at. So the biology of HER2 low versus the HER2 zero, which is HER2 negative, does it really matter in this what we are looking at? So there was very marginal differences. So we went by a PAM50. This is a 50 gene panel kind of expression score to see how much is the receptor style or how much is the basal-like versus the luminal type. So it gives us a gene expression about the tumors in the hormone positive group, and we try to see if there is a difference. So triple negative, as we all know, they are the basal type by PAM50 expression as well. The hormone receptor positive type is the luminal at PAM50, but the major point is it's regardless of whether it's HER2 low or not. So we looked at this profile to say that really it's there, but it doesn't give us much on the way of gene expression. Then we looked at the studies comparing HER2 low versus the HER2 zero breast cancers. There is really no prognostic difference between these two groups. These are all the studies that were done. The green bar in there shows the positive difference. Otherwise, all the black marks are showing no overall survival difference. So really, there is no overall survival in a nutshell comparing the HER2 low versus the HER2 zero subgroup. Then the last point, which is the pathology, which we deal with all the time, giving us this expression, is there really concordance? So this was a study published in JAMA Oncology 2022. It looked at different pathologists from a single center in which they collected all the breast tumor samples, and they said, okay, is this HER2 zero versus HER2 1+, which is the major kind of a goalpost that is moving. So we had a concordance of roughly 26% among pathologists on score 0 and 1. So you can see there was a large discordance between the HER2 zero and HER2 1+, because it's all immunohistochemical stains in the end. So you can see the other part of this summary of HER2 low breast cancer is this large proportion of patients is 50 to 55% is the HER2 low group. Predominantly is hormone receptor positive, and this is kind of what we did in our trial as well. Majority of the patients were hormone receptor positive. Prognostically and biologically, as I showed you, it's indistinct from the HER2 zero group, and there is unreliable scoring by immunohistochemistry. The last point, fluctuating expression over time. Really, this is not a standard, like it's going to be stable. There was expression changes comparing the early stage HER2 group compared to the metastatic group. So it's also fluctuating. So it all makes this complicated to deal with. So why do we care about this? We have seen that really there is no distinct biology that we are looking at. So it's not a unique subtype, but the HER2 low group is targetable. We can target this group, and that's what it makes it unique for this, the trial that I'm going to discuss it further. So they are currently, before this whole paradigm change, we were treating HER2 low group, which is the 1+, 2+ FISH negative, same as HER2 zero. And zero is expression less than 10%. So if its expression is more than 10%, it's the HER2 positive group that we look at. Does HER2 low status predict benefit of trastuzumab? In the studies, it said no. We could not find any benefit of using trastuzumab, which is the HER2 targeted therapy. And does HER2 low status predict benefit of other targeted therapy? That we will figure out in the next slide. So this is just a NSA BP B47 group, in which they looked at the HER2 low group, and they divided this into chemotherapy arm versus the Herceptin plus chemo arm. And you can see there was hardly any survival benefit in wasted disease-free survival, as well as the overall survival was kind of like the lines were on top of each other, really showing nothing, no signal in there. And there was, in this TDM1 group, there was a subgroup exploratory analysis in the study, and we looked at the HER2 low group with the TDM1, and it really again showed that we could not find out that TDM benefited in this subgroup as well. This was kind of a baseline that we went on to go to our study, which is looking at the HER2 antibody drug conjugate, which is trastuzumab deruxtecan, also called PDXD. So this is what we have, a highly active chemotherapy agent, which is the topoisomerase 1 inhibitor payload, which is attached to a cleavable linker. And we have got this antibody which attaches to the HER2. What happens is that it attaches to the HER2 receptor out there. It is internalized. The linkage is cleaved. Topoisomerase 1 inhibitor is released, and it attacks the cell. And the major point is that it attacks the neighboring cells as well, which is called the bystander effect. So bystander effect, again, it's again showing the same thing that we showed, penetration or release payload into the neighboring cells. This is kind of unique for the TDXD compared to the TDM1. And it makes this a little bit or kind of more better than the TDM1, which we were used to using. In vivo testing of the anti-tumor efficacy of TDXD and TDM1, you can see the waterfall plot in there. And you can see that the TDXD, which is the top one, it has shown in multiple models, showing a substantial benefit in the efficacy compared to the TDM1, which is down below over here. So ADC characteristics between TDM1, it is an anti-microtubule inhibitor, which is the TDM1. The ratio of the drug to antibody is less, and we have got cleavable linker in TDXD. So you can see like all of these markers are positive, and that's what makes it more attractive in our study. So Destiny Breast 01, this was a phase 2 study, kind of dose, noticing the dose which we can use. It came out that 5.4 milligrams per kg dose was the one that we wanted to go ahead with. And the primary endpoints were overall response rate by independent central imaging review. So Destiny Breast 01 did show TDXD showing a benefit, and you can see the waterfall plot. It showed the sum of the diameters which have been reduced on the study in this HER2 positive metastatic breast cancer. Notice that this was all covered. This was the metastatic setting. This is not the HER2 low group that we're going to discuss a little bit further. The Breast 03 trial, TDXD versus the TDM1 group. And it also showed that TDXD performed better in this phase 3 study, kind of giving us this progression-free survival investigator assessment endpoint. And you can see the hazard ratio is alarming or is substantial to be 0.27 compared to TDM1. We were banking on TDM1 for a whole lot of time before this study came, and Destiny Breast 03 in the metastatic setting of HER2 positive disease showed this substantial benefit. So coming to the Destiny Breast 04, which is the TDXD in the HER2 low group, and this shows that we were going for the HER2 low unresectable or metastatic breast cancer, and this was a randomized phase 3 study just presented in the ASCO 22 session. And this is the treatment protocol. TDXD was used in the 5.4 milligrams per kg every 3 weeks, and the other arm was the physician choice of chemotherapy. You could use capecitabine, eribulin, gemcitabine, paclitaxel. Primary endpoint was progression-free survival. Key secondary endpoints were the central review, PFS of all patients, and the overall survival. So you can see over here the hormone receptor positive group, which is the majority in this trial. They showed a substantial benefit with the TDXD. Median progression-free survival was 10.1 months compared to the physician choice chemotherapy of 5.4 months. And the p-value is significant. And all patients actually did benefit as well. So they were combined hormone receptor positive versus the hormone receptor negative group. So this was substantial. And then we had this exploratory endpoints kind of signifying the same theme that in the HER2 low group, we have got progression-free survival, even the overall survival benefit of 9.9 months in this study in the exploratory endpoints. Highly positive group. It was a big plenary session in which there was standing ovation for this trial. Subgroup analysis kind of shows the same pattern that it's across all kind of different hierarchies and different subgroups. We have got a benefit of the trastuzumab deruxtecan. This kind of waterfall plot kind of nicely illustrates the change in the sum of diameters of the cancer, and you can see that we have got a significant waterfall. And this is IAC1, which is the dark blue lines, and you can see that the dark blue and the light blue all show the significant trend in there. We always talk about side effect profile, and this is nausea is the major one with the TDXD arm, 73%. But if you look at the grade 3 or greater, it's roughly 5% in there. Neutropenia is another big one, but 14% was the grade 3. And we always expect, because essentially you are targeting a HER2 agent, but this is chemotherapy in a nutshell, which you're just delivering as a payload. So special effect, because people always ask about ILD and the left ventricular dysfunction. Not substantial, in my opinion. There was no grade 4 or 5 in the left ventricular dysfunction. There was, unfortunately, a grade 5, 3 events noted in the ILD arm, and these were highly monitored for ILD in the study. Published July 7th in the NEJM, trastuzumab deruxtecan in previously treated HER2 low advanced breast cancer. Dr. Modi presented this in the plenary. Going on the same theme, can we do better in defining HER2 low? As you said, like we are using a primitive method right now as well of the immunohistochemistry stain. And I showed you this concordance of the 28% in the HER2 zero compared to the HER2 positive. And you can see there was a 70% concordance in the 3+ group compared to the low group. So there is a big concordance if you have really positive HER2 receptor status. Are there alternative medicines, alternative means of measuring HER2 expression? This is, I think, will be the next big thing. We'll have multiplex mass spectrometry to analyze what's the immunohistochemical marker in the groups, and you can see that we are still in the studies for this, and this will be coming on soon. I will just take a few points about the future directions. We have got this HER2 trastuzumab deruxtecan. We have got Destiny Breast 6 coming, which is really looking at the ultra low. So that 1 to 10%, which is really defined as HER2 zero, we're calling that ultra low. So we are looking at trastuzumab deruxtecan in that subgroup. There is an immunotherapy component to it as well. We are combining this with durvalumab, and this is the Begonia trial. So TDXD plus durvalumab coming on, and we are showing this substantial benefit in the mass of the tumor over there as well. Talent study will be in the HER2 positive, hormone receptor positive, early breast cancer. And you can see, so there are all sorts of combinations coming in this HER2 low group with the hormone receptor positive, with the immune therapy checkpoint inhibitors. So watch out. I think this will be a game changer in the HER2 low group in which we are combining all these therapies. Last, I think I'll just mention a few trastuzumab duocarmazine, which is the antibody drug conjugate in development in the HER2 low space. We have got disitamab vedotin. This is also kind of in the same subgroup that we are looking at. And you can see overall response rates, 28% with trastuzumab duocarmazine and 40% in the disitamab arm. This is my summary slide. Kind of this shows that this is the first HER2 target therapy to demonstrate improved efficacy in the HER2 low group. It's in the metastatic setting and in the HER2 low subgroup that the people looked at, establishes as the new standard of care and potential improvement for roughly 50% of all metastatic breast cancers in this setting. I'll conclude this by saying I think TDXD has substantial benefit in the HER2 amplified group, as we know about, and then I'll just present this data in my HER2 to metastatic breast cancer, which will be coming on later, but it improves the progression-free survival and response rate in the HER2 1+ and 2+ metastatic breast cancer. HER2 is 1+ or 2+ in 55% of hormone receptor positive breast cancer, and this is the group that we are looking at and getting substantial benefit. Likely a new standard of care in the ER positive, HER2 low group of patients. And thank you. I think I'm a little bit exceeded on my time, but thank you very much for listening.
Thanks a lot, Dr. Asad. The next speaker is Dr. Habib Khan. He's a consultant clinical oncologist at University of Saskatchewan, Canada. He holds 2 fellowships and has done masters in clinical oncology, along with research in PET parameters in lung cancer. He is also a member of Royal College of Radiologists International Committee for promoting education, and has helped in organizing FRCR clinical oncology courses and lectures at Shaukat Khanum Hospital as well. Can I invite Dr. Khan, please?
Thank you, Dr. Bukhari. It's my pleasure and honor to be part of the Shaukat Khanum Hospital Symposium. I've been asked to present on genomic assays' role in adjuvant treatment for early breast cancer. I will be focusing on Oncotype DX and MammaPrint mainly. I have no financial disclosure for this talk. I acknowledge the help for the slides from Oncotype and MammaPrint teams. So when we make a decision about adjuvant treatment, hormone positive and HER2 new negative in early breast cancer, we usually take traditional factors, but now we have other tests that can help us in deciding treatment for adjuvant breast cancer. 2 of them, Oncotype DX and MammaPrint, are available. And in MammaPrint, there's an extension further refined, including Blueprint and Imprint 32. And other genetic markers and other subtypes are also important when we're deciding the treatment. Traditionally, we have used the prognostic factors and other factors to decide our decision regarding adjuvant treatment. Some of them are listed over here. With the use of estrogen receptor, progesterone receptor, and HER2 receptor, we can direct them much better and have a good outcome. Before we move on, I'm just going to emphasize slightly on about prognostic factors and predictive factors. Prognostic factors provide us information on outcome of a cancer, while predictive factors determine the degree of response to a specific therapy. Some of the examples are listed here. We can treat people who are estrogen receptor with anti-estrogen treatments. Similarly, HER2 treatments, we can decide with the anti-HER2 treatments, which favors the outcome. Whereas in the previous era before the anti-HER2, these people were not used to do very well. There are other factors that we take into account. Moving my talk, age and nodal status is also important. And now we have multi-gene assay signatures, which help us deciding the treatment. So Oncotype DX and other tests becomes more important in our decision grid. Prognostic gene expression-based tests for early stage hormone positive and HER2 negative is the main focus of my talk today. There are some other markers which can look into other subtypes to help us making decision, escalating or de-escalating treatment in breast cancer. Indicating a genomic test can help us make decision, especially in postmenopausal patients with node negative and node positive group. We can now make a decision with certainty at a degree. In premenopausal patients, we still have the outstanding question that we need to address. So I'm going to slightly touch on those things as well. So while we are now in an era of multi-gene testing, where we decide most of the decision in adjuvant breast cancer, depending on their outcome or their gene results. There are a number of tests available. Out of these, Oncotype DX tests and MammaPrint or Blueprint are the most common one being used at the moment. First of all, I'm going to talk about Oncotype DX test, which is widely available and was the first in the market. It looks into the 21 gene assays, which have different groups: estrogen group, proliferative group, HER2 group, invasive groups, and others, and there are some reference genes in it. When they combine them together and look into it and give us a score from 0 to 100, making easy for us to make a decision with a cutoff. We all know that the chemotherapy causes both short-term and long-term side effects. Name few: neurocognitive dysfunction, cardiac dysfunction, secondary cancers are most common, and this have an impact on quality of life, family life, and working life of a person. And we know that the vast majority of the patients with early breast cancer do not benefit from adjuvant chemotherapy. This has been highlighted in early breast cancer trialist group of 2012. This included about 5,000 patients, and this does have a small proportion of node-positive group. Again, most of our decisions are made on the prognostic factors when we were deciding. After that came the era of deciding based on the predictive markers as well. Just taking from the Oncotype DX as an example, NSABP B14, Trans-ATEC, and Plan B give us an idea about the prognosis of the disease in node negative and node positive group. Similarly, moving on, for the prediction of chemotherapy benefit, NSABP B20 and SWOG 8814 give us an idea about prediction or chemotherapy benefit. And their further precision was taken on by TAILORx and our expanded trials, which has shown us the good cutoff that we have a good confidence interval in terms of omitting chemotherapy in the patient who would not benefit generally. So what is the clinical evidence and utility in node-negative patients? So if you look at the NSABP 20 trial, which divided the early breast cancer, hormone-positive and HER2 negative patient into 3 groups, with a recurrence score of 0 to 10, 11 to 25, and anything above 26 or above. You can see the first 2 groups, there was no chemotherapy benefit, and we can avoid chemotherapy in this group, while there was significant benefit on patient who had score of 26 or more. Then came the TAILORx trial, which further, for the precision point of view, classified the intermediate arm. So we knew the intermediate arm, and we extended further. So they divided the group from 11 to 25 into further 2 arms, arm B and C, and look at the impact of chemotherapy or no chemotherapy along with the endocrine treatment. And this shows there was no significant benefit in this group in node-negative patients. Hence, we got more kind of secondary interval, distance recurrence-free interval, as well as overall survival. There was no significant impact. So it was a practice that we are now taking as a 0 to 25 as a patient with no significant benefit. This slide shows the age, as I mentioned previously, is an important point to think about adjuvant treatment when we are considering these gene assays. Anybody who was more than 50 years, there was no clinical benefit in recurrence score of 0 to 10, neither in 11 to 15, neither in 16 to 20. But if you look at the premenopausal, less than 50 years, there was about a small benefit in recurrence score of 16 to 20 of 1.6%. Similarly, anybody who's scoring more than 26 needed chemotherapy, but the group in postmenopausal, there was no benefit from up to 25, while in the premenopausal, there was a significant benefit, which is employed at 6.5%. So we have to look at the patient when we're deciding about the treatment options, considering the patient. So do our traditional markers or clinical risk factors have an impact on the genetic markers that comes on? Then we saw. So you can see the clinical risk low and high versus clinical risk or versus the recurrence score results of 0 to 25 and 26 to 100. You can see traditionally we would have classified 73% of the patient as high risk clinically, but they did not need chemotherapy. So we can avoid chemotherapy in this group. Similarly, with a patient with a high risk score, recurrence score of 26 to 100, were clinically low risk. So there were some patients in our clinical practice we always come across, they do not behave traditionally when we offer the adjuvant treatment. This has been replicated by a number of studies in different countries, which showed that there was no clinical relation of clinical risk group versus the genetic markers that we usually use. Did the tumor size, grade, clinical risk category have any impact? There was no predicted chemotherapy benefit in this group, and there was no concordance between them. Similarly, this graph also indicates there was no significant correlation with this group. So now we move on to clinical evidence and utility in the node-positive patients. SWOG 8814 established the recurrence score results were predictive of chemotherapy benefit in node-positive postmenopausal patients. Here you can see they divide into three groups. First group was 0 to 17, second one was 18 to 30, third one was 31 to 100. You can see the last group, 31 to 100, showed a significant benefit, about 19% in absolute chemotherapy when added to endocrine treatment, but there was no significant benefit in the group 0 to 17. 18 to 30, there was no significant benefit, but it's still, as we talk about, other factors might have an impact, so they need to be more precise about cutting off the recurrence score, so they did another trial. Here you can see the postmenopausal patient N1 with lower recurrence score result did not benefit from addition of chemotherapy in SWOG 8814. So they did our responder trial, which confirmed, which was a randomized trial looking into the cases of scoring 18 to 25, did they have benefit with chemotherapy added to the endocrine treatment. Most of them were postmenopausal, majority, and the premenopausal was 31%. And when you look at it, in the reported outcomes in N1 postmenopausal patient, 0 to 25 did not benefit from addition of chemotherapy to endocrine or any endpoint reported. Any of the other factors stands out: age, grade, tumor site, clinical risk, nodes, recurrence score results. We can see that there were no any outstanding outliers. But in N1, premenopausal women with recurrence score of 0 to 25 showed a modest benefit of 2.4% from chemotherapy. And you can see in this couple of graphs. So outcome from that was the postmenopausal patient with N1 disease, there was no benefit of chemotherapy with the recurrence score of 0 to 25 versus premenopausal patient had a 2.4% modest benefit. So this is the grid, shows you from our decision-making point of view, which one we need to consider and what kind of a discussion we have to take. In premenopausal, if you look at the last line, that there is a benefit in patient node negative with a group lying between 16 to 25. And in N1, throughout 0 to 25, there was a benefit. Similarly, we have to recommend chemotherapy, anybody who's scoring 26 or more. So this is the flow diagram or grid for making decision, which usually helps us that low clinical risk outcome and high clinical risk also have a benefit. So we have to keep in mind, still, this test does not allow borderline people. We still have to look into clinical risk factors as well. Sometimes they are helpful in making us a decision. This slide also shows for the benefit that no chemotherapy, we can avoid chemotherapy in a certain number, quite a significant number of patients, versus chemotherapy which is needed, which is a small proportion. The post hoc analysis in premenopausal women suggested the absence of regular menstrual periods might be associated with improved invasive disease-free survival, regardless of the treatment arm. There comes a thought of ovarian function suppression. So this is a common important thing that we have to keep in mind. There's still work to be done on this ground. And the rate of regular menstrual period lower in the chemotherapy arm compared to at any endpoint. And again, what I was talking about, ovarian function suppression or endocrine treatment. I'm going to move on to the clinical utility of MammaPrint and Blueprint. And we're going to focus, because they're divided into different groups, we're going to focus on ultra low, low risk, and high risk group. MammaPrint looks at the 17 genes, and the blueprint, which is enhancement, they look at the 80 genes of breast cancer. And when you look at it, they divide into five subtypes of ER positive and HER2 negative. They divide into ultra low risk, luminal A, low risk, luminal A, luminal B high 1, and luminal B high 2, along with ER positive, which function or behave as a basal cancer. So first question is, which woman with ER positive breast cancer may avoid chemotherapy? Similarly, what they're saying, if they score low or ultra low, we can avoid chemotherapy in this group. Look at the evidence. So people with no distant metastasis with 5 years are low risk. They did a full human genome and look into the ranking and give us a score. This has been ongoing since 2002. And you can see that the gene expression profiling predicts the clinical outcome of breast cancer. There are certain factors potential for distant metastasis, and these are controlled by certain genes. So they look at the low risk, high risk thing. MINDAC trial looked at the 7,000 patients which were enrolled, and this is level 1 evidence and for the MammaPrint to be considered. It looks at a 70 gene signature as an aid for treatment decision in early breast cancer, which was updated results of phase 3 randomized trial recently published. MammaPrint low risk women have an excellent distant metastasis-free survival at 5 years without chemotherapy. So we can see that clinical high risk, MammaPrint low risk endocrine therapy is alone is significant or sufficient for the treatment. So we can avoid chemotherapy in MammaPrint low risk group, regardless of the clinical risk. Does it have that effect on age less than 50 and more than 50? You can see people who were less than 50 years of age had 5% difference, while anybody who was more than 50 years of age or postmenopausal, there were no significant difference. So this leads us to think about our ER positive cancer in women less than 50 years, biologically different from cancers in women more than 50, or is the effect of chemotherapy different in women less than 50? Or is chemotherapy benefit due to secondary ovarian function suppression in this group? There was neoadjuvant breast Symphony trial looked into the response of neoadjuvant chemotherapy not affected by the age. So response to neoadjuvant chemotherapy was observed using the MammaPrint and blueprint. They look at the whole transcriptome analysis, identified no substantial differences in gene expression between the breast cancer due to age. They had looked at quite a sufficient number of genes. There were only 5 genes which stands out. So no difference in gene expression with age over or under 50, no difference in biology of ER positive breast cancer with MammaPrint low risk due to age. So MINDAC trial in ER positive HER2 negative looked into the node positive group as well. You can see the distant metastasis-free survival in clinically high or genomically low node positive did not benefit from chemotherapy as in 50 years of age. And distant metastasis-free survival, 5 years and 8 years, there was no significant benefit. When we look at the grid for making decision in postmenopausal and women with T1, T2, lymph node negative or positive, if they have a low MammaPrint, no chemotherapy is required. But if score a high MammaPrint score, the chemotherapy needs to be considered. When premenopausal, T1, T2 in node positive or lymph node negative, MammaPrint high needs chemotherapy, while MammaPrint low does not allow us to safely omit. But we have to take about shared decision-making with discussion of risk versus benefit, ovarian function suppression, or chemotherapy. So which postmenopausal woman with ER positive breast cancer may do well with less than 5 years of endocrine treatment? Because more treatment with endocrine, more toxicity, burden on healthcare and personal, social, and personal life. So they look into the low risk and they find that the ultra low risk, which is defined by the MammaPrint, we can consider omitting extended hormone treatment as well as maybe less hormone treatment. So mamaprint low-risk breast cancer patients' outcomes were excellent with little or no endocrine treatment. This has a significant impact. You can see 2 years of tamoxifen were used in 65% of patients, and 5 years tamoxifen, 35% of patients. There was no significant outcome difference. So in JCO, it was published that outcome of patient with ultra low risk 70 gene signature in MINDEC trial, we can consider omitting hormone treatment or maybe less hormone treatment as well. The excellent outcomes from our ultra low risk patients receiving only endocrine or no endocrine treatment, you can see the curves are usually lies overlying each other. So all ER positive women would be advised to take anti-estrogen, will experience severe toxicity and wish to discontinue. If they are mamaprint low risk or ultra low risk, it may be safe to stop early. In ultra low risk, they should continue in low risk group. Sorry, there's a mistake. So which postmenopausal woman with ER positive breast cancer may benefit from extended endocrine treatment? Here, mamaprint low risk, not ultra low risk, luminant A people may be considered for extended hormone treatment, which is presented in ASCO 2021, utility of 70 gene mamaprint assay for prediction of benefit from extended letrozole therapy in NRG oncology group and NSABP 42 trial. You can see the extended hormone treatment was used, letrozole for further 5 years, which has shown the benefit of 3.3% and placebo for further 5 years. Can we define genomically identify who will benefit? Here we look into it. You can see disease-free survival events were low. In mamaprint low group was 7.8. What high, obviously we know they usually need chemotherapy as well. And breast cancer-free interval, you can see with the mamaprint low has a significant benefit. So extended endocrine therapy benefit in mamaprint risk groups. We can see the low risk group had benefit, significant benefit of addition extended hormone treatment in this group. When we're coming towards the end of our talk, so which ER positive breast cancer are clinically similar to triple negative? So sometimes we see the ER positive breast cancer, they don't behave like ER positive breast cancer. So they further classified, which is very interesting, by a blueprint, which is an AT gene assay, functional molecular subtyping. A diagnostic gene profile molecular subtyping of breast cancer associated with treatment response. And there were some overlying intrinsic subtypes you can see with the blueprint PAM50, and they identify 32 genes with the ER response elements in their promoter. And this chart defines how the overlapping cancers we can find in our daily clinical life. You can see the HER2 overlap basal ER positive. They do behave genetically different way. There are other subtypes as well, but in the light of time, I'm just going to skip through it. They are further looked into the triple negative can decide us making decision, keep cytomel adjuvant treatment. Similarly, some of the ER positive behave like triple negative, so we can use those one. In general, can we predict ER positive breast cancer will respond to neoadjuvant chemotherapy? This is something they have shown in the trials, which ER positive breast cancer will respond to neoadjuvant endocrine treatment as well. So this is a grid which makes us understand about the mamaprint outcomes and may help us in making decision in adjuvant breast cancer patients. So I will finish my talk here. There were a number of posters presented in ASCO 2022 outlining the use of mamaprint and blueprint and utility in breast cancer. Imprint 53 gene signature identifies a subgroup of hormone positive HER2. They may benefit from breast cancer immunotherapy as well. These are the future trials that we're gonna keep an eye on and watch the space for it. Thank you.
Thanks a lot, Dr. Khan. Our next speaker is Dr. Ahmed Hanif. He's an assistant professor of medicine at Guy Singer Commonwealth School of Medicine, United States. He has been awarded Best Basic Science Research Award on his research in survivin protein in neuroendocrine tumors, and he's a principal investigator of more than 15 trials. Dr. Hanif, please.
Assalamu alaikum, everyone. It's not coming over there. There we go. Okay, so this is my CV over here. No disclosures. Let's get right to it. How many of you are from medical oncology? Okay, so a fair number of you. Okay, so you already know what I'm going to talk about, so you're not going to learn anything new, but I just want to touch on all the important points that are very significant in the shaping of the management in the current period of the hormone receptor positive early breast cancer. As you can see that out of all the breast cancer, and this is only the data from the United States, 74% of the breast cancers are hormone receptor positive, HER2 negative. So by far, this is the most important talk of the day. Just to go back a little bit to the basics about the staging, just very, very superficially, anything less than 2 centimeters T1, between 2 and 5 centimeters T2, more than 5 centimeters T3, and invasive is T4. And I'm just going over that because I'm going to use these T1, T2, and 1 a lot in this presentation. And clinically, movable axillary node metastases are N1, immovable axillary nodes or ipsilateral internal memory nodes are N2, and anything more than that is N3. And pathological node classification, 1 to 3 is N1, 4 to 9 is N2, and more than that is N3. So the real issues regarding management of early breast cancer are we doing too much for these patients? Especially the very early stage, the stage 1 and the stage 2. So I'm not going to talk much about stage 3 because stage 3 is pretty straightforward. You kind of do everything. You do need to treat the main cancer, the breast, and you do need to treat the axilla in some way, and you do radiation, and you do chemotherapy, and you do hormonal therapy. You do all of that. So the real question is, what do you do for the stage 1 and the 2? So what should be the management scheme here? So we need to define the extent of surgery, what constitutes a negative margin, contraindications to breast conservation surgery, what is the current role for hypofractionated breast radiation, what are the role of surgery after neoadjuvant therapy, and most importantly, the adjuvant therapy. So extent of surgery, there have been some classic trials, the B4 trial, which was started in 1971. And after 25 years, they found that there's no difference in overall survival if you treat these cancers with a radical mastectomy versus a simple mastectomy. And then further to elaborate on the same issue, the B6 trial showed that there's no significant difference in overall survival in these early hormone receptor positive breast cancers between total mastectomy and breast conservation therapy combined with whole breast radiation. What constitutes a negative surgical margin? This doesn't make much sense. For invasive disease, it's just no ink on the tumor. But for DCIS, it's 2 millimeter. And that's because of the scatter of microcalcification. If they're DCIS plus microinvasion, it's considered as DCIS. And classical LCIS, we don't worry about the margin. Even if there's LCIS at the margin, it's not an indication for re-excision. Lymph node mets, if there's more than 2 millimeter, we call it a macromet. If there's 0.2 to 2, we call it a micromet. And then there's isolated tumor cells, which are anything more than 200 cells, but less than 2 millimeter. And these are actually classified as negative nodes per NCCN. But this is the topic of investigation right now, so that's why I put it there. Breast conservation therapy, most of the time that's the right answer, but there are some absolute contraindications, like if the patient is pregnant, cannot get radiation afterwards, or very diffuse or malignant appearing calcifications, or diffusely positive pathological margin. Just one positive pathological margin is not a contraindication. It's a relative contraindication. Inflammatory breast cancer, you always go with mastectomy, and homozygous mutation of ATM for obvious reasons. They cannot get much radiation because of the risk of secondary cancers. Then relative contraindication, multicentric disease, basically anything that the surgeon is not comfortable taking out is a relative contraindication. So prior radiation therapy can can limit the amount of new radiation that you can give. So mastectomy might be needed in that case. Connective tissue disease might be a challenge here too. And then known or suspected genetic predisposition. Hypofractionated breast radiation is kind of the way to go these days with the early stage breast cancer, because for stage 1 or 2 invasive disease, the classical way to do it was give 40 to 50 grays to the in a tangential fashion over 25 to 28 fractions. So that would take about 5 to 6 weeks. But now with the hypofractionated whole breast radiation, it's about the same amount of radiation, but it's given over 3 weeks, so 15 fractions. And then there's another type of radiation called accelerated partial breast irradiation. It's not conclusive what cases can receive that, but right now it's favored for very early and low grade invasive or low grade DCIS. And now we come to the most important part of management of early breast cancer, how to decrease the lymphedema risk, because it's a major problem after breast cancer surgery. So after complete axillary lymph node dissection at level 1 and 2, the risk of lymphedema in the upper extremity is about 20 to 30%, which is a lot. But after sentinel lymph node surgery, the lymphedema rate drops down to about 6 to 7%. So the question is, which patients can we spare the lymph node dissection in? So let's start off with the easy question, like the B32 address, that if the sentinel nodes are negative, then whether you do axillary dissection or just sentinel lymph node resection, it doesn't make a difference. So you can see all the outcomes are crossing the 1, so that means they are not significant. So that's easy. If the sentinel nodes are negative and clinically they are negative, then you don't need to do dissection. But this trial is the most important one, where they took women with T1 or T2 tumors, which were clinically negative, but on sentinel lymph node biopsy, they found 1 or 2 positive sentinel lymph nodes. And then whether you do the axillary lymph node dissection or the sentinel lymph node dissection, it doesn't really make a difference here. And when they stratify by node positivity, the non-inferiority remains. So that's another thing, that for hormone receptor positive T1 and T2 tumors, which are clinically negative, if 1 or 2 sentinel lymph nodes are positive, then still complete axillary lymph node dissection is not indicated. So based on this trial, we didn't find any difference in overall survival and disease-free survival. And the conclusion is that we can avoid axillary lymph node dissection in clinically lymph node negative with 1 to 2 positive sentinel lymph node. Now remember that this trial only had patients who underwent breast conservation therapy, so we don't have that data with mastectomy. None of the patients underwent neoadjuvant chemotherapy, so that data is not available. And none of the patients were allowed to skip radiation. So those will be the scenarios that will not fit in the definition that we use to select patients in this trial. Now, post neoadjuvant, the data is even murkier. So if sentinel lymph nodes are negative, then no further axillary surgery is indicated, although the false negative rates would be high because you never know if those lymph nodes were really negative to begin with, or if this is just a pathological complete response. But if the sentinel lymph nodes are positive after neoadjuvant chemotherapy, then at this point, the recommendation is that you still do the complete axillary lymph node dissection. And this alliance trial, it's looking at if there's a positive sentinel lymph node after neoadjuvant chemotherapy, like the scenario above, can we replace the lymph node dissection with radiation? And we're still waiting for the the data. And the B51 trial, again, is looking at biopsy-proven node-positive disease before we start the neoadjuvant chemotherapy, and then we do neoadjuvant chemotherapy and the node become negative. So kind of like the first scenario, but here we do know that this is a false negative because the nodes were positive before the start of the neoadjuvant chemotherapy. And this trial is also looking at whether we can just get away with radiation versus don't do anything afterwards. The other big thing is for elderly patients with low-grade and early breast cancers, can we omit radiation? And the answer is this trial, where they looked at more than 70 years of age with ER positivity and T1 disease with clinical N0. So very early stage, low-risk breast cancer. And if it's treated with breast conservation surgery, and afterwards it was randomized to tamoxifen with or without whole breast radiation, and there was no difference in disease-free survival or overall survival. The local regional recurrence was 8% lower with radiation. So the radiation does decrease the risk of local recurrence, but overall survival was the same. So this is potentially one group that can skip the adjuvant radiation even after breast conservation surgery. And post-mastectomy radiation, if 1 to 3 lymph nodes are positive, then you radiate the chest. If more than 4 lymph nodes are positive, then you radiate the chest and the nodal basins. And if the periclavicular nodes are positive or the mammary nodes, then you have to do the complete radiation. Now, I know Dr. Habib not touched on it, actually, he went into it in great detail, and I'm going to just touch on it, these few trials, because this is a major part of management of early hormone receptor breast cancer. So the TAILOR-X trial was the one that finally proved the predictive nature of the Oncotype score, and it divided patients into low risk, intermediate risk, high risk, and the low risk, they had excellent outcomes with just the endocrine therapy, and the intermediate risk were defined as the recurrence score of 11 to 25, and they were divided into endocrine therapy versus chemoendocrine, and the results were pretty comparable. And the high risk got chemoendocrine therapy. And if you look at all the subgroup analysis, so pretty much the same outcomes. Really, you can't see 2 lines that are closer than this. But the lines do separate on subgroup analysis for patients who are less than 50 years of age. And in that, you can see that there is some benefit of chemotherapy for Oncotype score of 16 to 20, and the benefit is even larger when the score is 21 to 25. But that is when the age is less than 50. So just summarizing, the TAILOR-X trial showed us that if recurrence score is 21 to 25, then chemotherapy does benefit whether your clinical risk is low or high. If the recurrence score is 16 to 20, then only if the clinical risk is high, then you get some benefit from chemotherapy. So again, Dr. Habib went over it in great detail. That you take the recurrence score and you take the clinical risk, and then you decide, recurrence score of 0 to 10, any clinical risk, you don't give any chemotherapy. And if recurrence score is 11 to 20 and your clinical risk is low, then you go for tamoxifen. And here there's everyone else who should consider either chemotherapy, but there's one issue that with these patients, when they get chemotherapy and they derive a benefit, there is this hypothesis that the benefit might just be because of the ovarian function suppression because of the chemotherapy. Because a lot of these patients, they stop menstruating and they stop ovulating during the chemotherapy. So the benefit might be just coming from the ovarian function suppression. And that's why the alternative recommendation here is that either do chemoendocrine therapy or consider ovarian function suppression with aromatase inhibitors. The other important trial for Oncotype is RxPonder, and the TAILOR-X basically looked at lymph node negative or microstatic N1 metastatic N1 breast cancer, and it said that age less than 50, recurrence score 16 to 25 may derive chemotherapy benefit, and age more than 50, recurrence score less than 25 have no chemotherapy benefit. But how can we extrapolate that to lymph node positive patients? We cannot, and that's why the RxPonder trial came in. And they stratified the patients by recurrence score, but they included patients with 1 to 3 lymph node positive. And the results show that postmenopausal, if your lymph nodes are positive, doesn't really matter. It's you don't derive any benefit from chemotherapy, but premenopausal you do derive a benefit. So that is interesting. That premenopausal, even if the lymph nodes are positive, you can use this data. And this is, I know these are really hard to read, but if the recurrence score is 0 to 13 in premenopausal women with positive 1 to 3 lymph nodes, then you derive some benefit from chemotherapy, and that magnifies when the score is 14 to 25. There is about 6.2% benefit with chemo. And that's just another way of looking at it with the menopausal status. So our RxPonder conclusion was that recurrence score of 0 to 25 was prognostic, but did not show a treatment interaction with chemotherapy. But postmenopausal women with 1 to 3 lymph nodes with recurrence score of 0 to 25 did not benefit from adjuvant chemotherapy and can safely forego chemotherapy without compromising invasive disease-free survival or overall survival. But premenopausal is the one where this trial showed a benefit that if premenopausal women with early stage hormonal receptor positive breast cancer and just 1 to 3 positive lymph nodes, and their recurrence score is 0 to 25, still they derived benefit from chemotherapy. And the question remains, is this impact of ovarian function suppression from chemotherapy? And right now we don't know. So if the patient is not a good candidate for chemotherapy, then another good option for them would be ovarian function suppression and add an aromatase inhibitor. And this is the current NCCN guidelines, which pretty much say the same thing. I'm not going to go too deep into it because of time. Same thing. So the other big question is, what is the optimal duration of hormonal treatment? And this is the ATLAS trial that showed that 10 years of tamoxifen versus 5 years is improves the disease-free survival and the overall survival. So after 10 years of tamoxifen, the only complication was that the endometrial cancer incidence, it went up by 3.1% versus 1.6%. But then other trials also compared 10 years versus 5 years of aromatase inhibitors, and there's no endometrial cancer incidence with the aromatase inhibitors. So to counter that, now the recommendation is that after 5 years, especially if the patient is menopausal by that time, then switch to an aromatase inhibitor rather than give 10 years of tamoxifen. Just briefly talking about the aromatase inhibitors, they are the non-steroidal ones, the anastrozole and the letrozole, and the steroidal one, the exemestane, and their side effects are arthralgias, myalgias, osteoporosis. There have been countless studies, not countless, 3 studies that show that extended duration of adjuvant aromatase inhibitor is associated with a small reduction in breast cancer recurrence and second primary breast cancer events. And we know that from SOFT and TEXT trial, they took ERPR positive patients with in the premenopausal range. In estradiol in the premenopausal range, basically premenopausal patients with ERPR positive, and they did stratify the patients with whether they received chemotherapy or not, and then they further stratified them by giving them tamoxifen for 5 years versus ovarian function suppression plus tamoxifen for 5 years versus ovarian function suppression plus exemestane for 5 years. And guess which one was the winner? The ovarian function suppression with exemestane had the best results. So just a quick summary of these trials, because these were landmark trials that changed our practice. They were premenopausal patients. Some of them received adjuvant chemotherapy, some of them did not. And the disease-free survival was 71.4% with tamoxifen. It increased a little bit with tamoxifen and ovarian function suppression. and increase further if we used exemestane along with ovarian function suppression. So that's why for the highest clinical risk in these patients, we do recommend ovarian function suppression and add an aromatase inhibitor. The overall survival data is still premature, but the disease-free survival, pretty significant here. And that is again showing that if the in the soft and text trial, if we stratify by just the women who are less than 35 years of age, the exemestane and the ovarian function suppression group wins by some margin, both from freedom from breast cancer and freedom from distance recurrence. Neoadjuvant hormonal therapy, not very favorable in practice right now, but there is some data. It can produce a pathological complete response of 1 to 8% and an overall response rate of about 40%. So in older postmenopausal women with very low-grade tumors and which have a high percentage of hormone receptor positivity, certainly this can be considered. And then the latest development in the management of early stage breast cancer, hormone receptor positive, is the Monarch E trial, which looked at high risk early stage hormone receptor positive breast cancer and looked at whether we can decrease the risk of recurrence by adding abemaciclib for 2 years, which is a CDK4/6 inhibitor. It's taken twice daily. It has to be taken every day. There's no 21 out of 20-day cycle. And the results are very significant. The abemaciclib clearly increased the invasive disease-free survival. And then another one. Okay. So in the PALACE trial, the adjuvant endocrine therapy plus minus palbociclib, that did not show any difference. So palbociclib, we're going to talk more in my next talk on advanced stage hormone receptor positive breast cancer. Palbociclib consistently has not shown any benefit in the overall survival, and in this case, even invasive disease-free survival. And the Penelope-B trial basically further, looked at the benefit of palbociclib in the neoadjuvant setting. And again, not much difference. So the NCCN recommendation right now is only for abemaciclib, and it's only for this specific group of patients, the hormone receptor positive, HER2 negative. And they define high-risk breast cancer as greater than 3 positive lymph nodes, or if 1 to 3 positive lymph node, then you have to have either grade 3 disease or tumor size more than 5 centimeter, or Ki67 of more than 20%. And in these patients, 2 years of adjuvant abemaciclib can be considered in combination with endocrine therapy. Thank you very much.
Thanks a lot, Dr. Ahmed Hanif. And I would request you if you could sit in the discussion panel. So this is the question session, answer session now. Has anyone got any questions? Could you please come on the mic, please, Dr. Musaddiq? I'm okay.
So, Assalamu alaikum. My name is Dr. Musaddiq and I'm a fellow in medical oncology. So the session was overall very informative, and all of the speakers did elaborate the early management of early breast cancer very well. So my question is from Dr. Muhammad Salim, if he can answer. How would you treat a patient with HER2 positive and early breast cancer with tumor size of less than 3 centimeters in a male patient? Because there was only one male patient included in that trial, in APT trial. And another question is, how would you treat a patient with less than 3 centimeter tumor size with other high risk features like grade 3 and lymphovascular involvement? So.
I'm Dr. Khan, Habib Khan. I'm answering for Dr. Salim. So excuse if I don't complete everything. So if I get it right, you're talking about 3 centimeter HER2 positive, irrespective of hormone receptor, breast cancer, neoadjuvant chemotherapy we're talking about. So the trial,
Adjuvant chemotherapy.
adjuvant chemotherapy, T3, for HER2. So you're escalating or de-escalating trial.
Yeah.
Your Persephone trial versus 6 months versus 9 months.
No, according to APT trial that.
APT trial, okay. So is there a significant difference? Should we carry on doing the full 12 months or less than 12 months is sufficient for these group? So in postmenopausal patient, if you do like APT trial, weekly Taxol along with trastuzumab, that seems to be sufficient in node negative, low risk group. If you're talking about high risk group like ER negative, grade 3, or tumors have shown some histological features of more aggressiveness, then you have to look at the patient as well. So either patient's fit, what talking about mainly what we use APT in elderly patient who cannot have hold the treatment. They usually sufficient node negative. These patients we usually look at it. If you look at the basal type, like the ER negative, then you will think about doing chemotherapy. So if you look at a trial which use platinum-based chemotherapy in this group, if they are young, node negative, would we try to consider platinum-based chemotherapy in this group along with trastuzumab in those groups? So you can think about it, but as I say, not one size does not fit all. APT3 is for the low risk group. Mainly I would consider. Similarly with Persephone, low risk group, you can consider in a small number of patients that are doing 6 months versus 9 months or a year. So you can de-escalate the treatment dose group. But if you think clinically very high risk and their high risk feature, age-wise and other features, if you want to do, I would give the full chemotherapy. So if in the apps, otherwise there were a few slides in Mama Brent as well, which identify a high risk group. So you can look into those things, which has a feature in neoadjuvant breast symphony trial, which look into these group, either responsive ER positive group, but similarly, they're doing something in the HER2 positive patients as well. So overlying is always, we're not going to get a simple answer. Clinically low risk group, lymph node negative, low grade, APT trial is sufficient. Elderly patient, they cannot sustain the whole chemotherapy, toxicity would be higher. Yes, I can think of those things. Thank you.
Yes, please, Dr. Abdul Manan, please.
And I have the question that can chemotherapy be, can we do an oncotype DX test midway in the chemotherapy? Like Dr. Ahmed initially said, anybody who has the surgeon feels the surgery will be not possible upfront. So that's a relative contraindication. So in that scenario, if a hormone positive patient comes to you and she started on a chemotherapy and she's not tolerating it well. So can we do the oncotype D score midway in the chemotherapy? And that oncotype D score would be done on the surgery specimen, or will it be done on the initial biopsy specimen?
So doing it midway, first of all, the question is going to be, what are we going to achieve by that? Are we willing to forego the chemotherapy in the middle and say that whatever chemotherapy we did was not for much benefit, and then just move on for surgery? I think one question is clear. There's no data for, or Dr. Habib can correct me, for doing oncotype testing after the specimen has been treated with chemotherapy, and it can induce further mutations, can complicate the things. But neoadjuvantly, I mean, it can be used to select whether somebody is a good candidate for neoadjuvant chemotherapy or not. Now, this is off of the guidelines. But the thing is, if we are saying that the genetic makeup of the tumor predicts response to chemotherapy in the adjuvant setting, then by some major extrapolation, we can say that that benefit should be present in the neoadjuvant setting as well. How much, or whether it's going to translate into clinical benefit, we don't know. We don't have good data. I think we have 1 or 2 small studies that show that in neoadjuvant, the oncotype can be used to select patients for neoadjuvant, but that's it. And in the middle of the therapy, I would just see if the patient is not able to get treatment, and that's it, then the patient has to stop. And if you started based on some reasoning, then and the patient has enough performance status to complete the treatment, then go ahead and push the patient to complete the treatment of however cycles you initially planned for. Dr. Do you want to add something?
You want to extend on the question?
Another question is, does the age have an impact on oncotype DA score? What if a 64-year-old diabetic hypertensive has a high recurrence score of 44, borderline fit? What would be the panelist approach on treating such a patient?
Which score you said?
Oncotype DX score of 44 in a 64-year-old.
Okay.
So we are defining these. First, we have to clarify what we are talking about. Okay. So if you're talking about anybody premenopausal or postmenopausal, so we have a cutoff from the trials more than 50, less than 50. So we stick to that one. So postmenopausal. So simple as postmenopausal, ER positive, HER2 negative, clinically high risk, low risk. So it's a low risk group, ER positive, grade 1 or 2, because grade 2. So this is an intermediate group, if you want to drive into it. They drive more benefit from hormone treatment, if you're looking into it. If you go for traditional prognostic markers like Nottingham Prognostic Index, adjuvant offline at the moment, or any other MSK model, they would be having benefit of 3 to 5% kind of thing, roughly. If you do the on-contact DX in this group, it's not certain they're going to turn out to be low risk or high risk, because this is this concordance with the clinical group. They might be different. They might score high or low. 43% we looked into it, which were classed as a low risk, found out to be high risk. Similarly, 73% will be classed as a high risk, found out to be low risk for oncotype DX. So there's no such correlation genetically versus the clinical markers. We looked at the tumor size in our talk. We looked at the grade as well. There was no concordance because they can turn out either way. There's no significant way safely. But you combine them together on a borderline area, we always have a default value to go back to our basics. So if you think it's a borderline 25 to 30 and clinically low risk and patient does not want to have chemotherapy, we have to be very upfront about it. Say there is a proven benefit from the trials, but there may be some overlapping on this group, and you can consider extended hormone treatment in this group. But again, I would go for, rather than oncotype DX, I would go for the MammaPrint for that one. That would provide me more information for the extended ultra low risk group. So there are certain ways to go around. There's no right answer, but I would offer, if they are high risk oncotype DX score, I would offer them chemotherapy. So node negative, I usually go for the anthracycline, cyclophosphamide chemotherapy for 6 cycles are sufficient. In node positive patient, addition of taxanes are helpful. But if the recurrence score is very high, even in the young patient, I intend to use like a FACT chemotherapy, which usually gives us a box standard kind of a compliance would cover. And there's a survival benefit when you add the taxane in a high risk group as well.
So in Pakistan, we do not have MammaPrint, and if there's a patient who has a high risk 44 recurrence score and she's 64, so I think we will give chemotherapy. And as Dr. Habibullah said, AC6 cycles or taxanes if it is not positive. So I have a question from my speakers. In extended trial, they used Herceptin preoperatively and then the Ratinib pathologically present if there was a disease. And then in Catherine, again, Herceptin and DDM1. So now we are using double Herceptin and pertuzumab. So in which patients will continue with Herceptin pertuzumab doublet? Where will you give Xnet and when DDM1?
It's an excellent question. So from the trials, so you have to look at the trial when they're coming from. So when the affinity trial, which uses adjuvant pertuzumab and trastuzumab in adjuvant setting in certain groups, that was happened when we did not have the advantage of having Kadcyla in adjuvant treatment with the after neoadjuvant treatment. So first of all, if they have a neoadjuvant chemotherapy, either doublet or single, they have a residual disease at present, I would consider Kadcyla as per Catherine trial. First. Second thing is about, do we consider de-escalating treatment using pertuzumab in certain group, either it's going to be beneficial. Although there was statistically significant, but there was a lot of discussion regarding it when we discuss about approving it in certain groups. It was turned out to be the node positive one, where the highest risk group have a benefit from doublet adjuvant treatment as per affinity trial. So in clinical practice, I would use doublet chemotherapy, trastuzumab, pertuzumab in neoadjuvant setting, see what the response is. If there's residual disease, I will use Kadcyla. Now, after finishing Kadcyla, as per extended trial, can we consider further extending the treatment with the I think if you look at a subset of neratinib, the brain metastases were very low kind of thing. So if I got a high-risk patient fit, I must say fit again. So you have to be very careful about when using neratinib. So if they're fit, I think it's quite reasonable to look at it. Are there any other new molecules coming into the brain? Tucatinib, watch this space. It might be much more tolerable and may work better, but still we don't have the evidence yet. But watch this space. So I think in high-risk people, neratinib has a role and we need to consider. You can start after a year finishing the treatment. So you've got a bit of a leeway that way you can use it and safely.
I completely agree with Dr. Habib. Neratinib was the unfortunate drug that came on right at the time when Perjeta was approved. So the data become murkier because nobody knew where neratinib would fit in the adjuvant treatment after the Herceptin and the Perjeta as neoadjuvant. So the last time I used neratinib was around 2017 or 2018. And from what I remember, patients had a lot of diarrhea on that. So as Dr. Habib said, they had to be really fit to tolerate the side effects. But in the odd patient who does not tolerate the Perjeta well because of cardiomyopathy or something else, I mean, it could be tried at some point, but this will be without having the backup of any data.
That question, yeah.
My name is Dr. Sadaf. I'm a surgeon here. My question is that I'm not working in Shaukat. So I work in a limited resource setup, and in Pakistan, especially where the genetic testing and genomic testing is not common, and still we are very new to this idea and want it to come in this country. There is a lot of cousin marriages, and we know that there are many patients below in the family, two sisters, lower the triple negative breast cancers with multiple family members, and they cannot afford the genetic testing. My question is that, can we justify the starting the tamoxifen, because you are saying that it is 62% risk reduction in them. Number two is that question is that after the 5 years of that treatment, how would the patients who don't go for their risk reduction by the surgical treatments in BRCA positive patients inherited, how you follow up those patients for the breast cancer risk reduction when you stop the therapy in those tamoxifen patients? Two questions. One is, in limited resource country, in Pakistan, without the genetic testing, can I start them with on the basis of history with triple negative cancers, multiple family members, tamoxifen? And the second question is that after 5 years, how you reduce the risk in your diagnosed patients with the BRCA1 mutation?
Let's take one question at a time. Okay. I'm not the prophylactic or geneticist, but I will try to answer as much as I can. My colleague, I was looking for him. So the first question about what to do in the high-risk patient who are suspected with a significant family history, and how would we approach? So Gale model, simple as that. Use the simple clinical markers that you can do. Justify yourself as much evidence that you can get. Considering without genetic is very difficult. So second part of your question. So how long you need to give? Now you're giving a strong drug to a patient who does not have a disease or you're suspecting. Ethically, it's going to be very difficult to justify myself giving somebody 3% chance of having endometrial cancer in those group, and the benefit I cannot justify. Although this risk reduction of 0.5, hazard ratio of 0.5 or 0.47, whatever you want to quote it, but here you don't have established diagnosis, they get a high risk features. Clinically, you are. But if you have like a 5 family members, immediate family members, and you think they're going to be harboring, there's a good chance they might fall into 1/3 of those people who might not have it as well. So I think it's with a strong family history, if you want to try it, 2 years would be okay. Answer to that one. Try postmenopausal, I would consider anastrozole rather than using tamoxifen. That's what I was saying, more risk of clots and other stuff. Coming to the second part of your question about BRCA gene mutation, what to do prophylactic, surgical prophylactic bilateral mastectomy and ovarian surgeries are usually helpful for reducing the risk. Nothing goes to zero. Anything else you can do? There's a small study showing the use of tamoxifen might reduce the chance, but they are genetically distinct from other hereditary breast cancer. So you have to look in the different. So have we used a olaparib or PARP inhibitor in those group might be helpful. I think we're a long way from that at the moment. We're just coming into the adjuvant setting with the Olympia trial. Are there going to be anything more in new adjuvant setting? And then we come into the prophylactic setting kind of thing. I think still we're going to use the conventional kind of approach. Consult the patient. I think that's the best thing to do. Make them realize they are high risk to go through the standard procedure. And if you think there are certain ways to approach a genetic marker, and I've been told, hopefully Shaukat Khanum might be running the NGS kind of platform that you can get some information about making those decisions. So would be helpful.
Yeah, I agree, because without a genetic testing, I think I would tell them to get themselves checked and get their mammograms done and come to the doctor very frequently. And if there is, and so that we can detect them and diagnose them early rather than going for chemoprophylaxis, or I think I won't do it. And I would go for the genetic testing and only then I'll rate them. Abdullah, what's your take on it?
Sorry.
So how would you do? Because we are living in Pakistan.
Well, I think Dr. Fawad Khan would have been the most appropriate person to answer this question. It was a very good question, but he basically apologized. He just reached this morning and was not feeling very well. But I will pass on your question to him as well. Is it okay to break now? Because we have to meet again at 2 o'clock.
Just one question, Dr. Habibullah. So which patient premenopausal who has a borderline score like 25? So which patient you are comfortable giving the hormonal therapy and not offering chemotherapy, and which patient you will say, no, these are the 4 or 5 things I think she should be given chemotherapy?
Thank you. So if you're talking about node positive, node negative premenopausal with oncotype DX score of 20 to 25. Okay, these are the intermediate group. There was some benefit in this group, so you have to have a consult. I might consider, if they are clinically high risk, to consider chemotherapy in this group. I'm just making it simple. Okay,
Like
high risk means Chi-67, grade 3, large tumor, T4 tumors, and things like behave inflammatory markers, basal markers, if you can find out. These are the things which makes you think about giving chemotherapy would benefit in this group. So there would be, I'm not talking about getting a mammograph at the moment, but that would be, yes.
Thank you.
So can we finish the first session? There will be a 30 minutes break now, and we join again at 2 o'clock, please.
So
Thank
Thank
you
you very much.